Moshi Moshi. Let's talk about the future. So, this is the Evergood Podcast where we focus on healthcare, education, innovation. And today is going to be a really interesting twist. And I'm really excited to have our guest today because we're going to talk a little bit more about technology, not necessarily healthcare education, but it's all good because it all actually mixes together. Part of becoming a healthcare worker these days is to understand the technology that you're going to need in your workspace, and also how technology is driving improvements for the future, streamlining processes, et cetera. And so today we have Katherine Kim. And interestingly enough, we met back when I was working at the Betty Irene Moore School of Nursing. And it's a very fitting thing to talk about because that was actually some pretty amazing healthcare education innovation in and of itself as we established the Betty Irene Moore School of Nursing at UC Davis. And I was working in the communications development team, and Kathy was one of the first PhD students at BIMSUM. No, we're not supposed to say that. It's the Betty Irene Moore School of Nursing. So welcome, Kathy. And how about you introduce yourself? You came into the PhD program at the Betty Irene Moore School of Nursing with an amazing product, and so maybe that's a good place to start. But
Sure. Thank you so much, Kristy, for having me on. So I'm Kathy Kim. I'm the founder and CEO of Health Tequity, which is a company dedicated to bring the best of digital health to community health. I have a long, background in healthcare services. I've worked in hospitals and medical groups and clinics, and did that for many years before coming back to the PhD program. And I made my switch to information technology while I was working at a medical group in San Francisco, trying to figure out how to streamline managed care for a large independent practice association of physicians. So I got a chance to explore how to use the internet and IT products to try and streamline operations for the medical group. So I bring that healthcare background and the technology development background with me when I started the PhD program. And I have continued leveraging my PhD and the healthcare and IT background to starting this company, Health Tequity, now.
right. I loved learning about your work when you were the PhD candidate, because it was really innovative at that time, and it's actually still very innovative. I think there's a lot of, in a general sense, healthcare is not necessarily the quickest at adopting technology. And if I recall, you were creating an app that was helping to connect providers with youth to manage their weight, right?
That's right. Yeah, we were working with San Francisco General and their Family Health Center, as well as a local high school, Mission High School, and their wellness center, which was actually located in the high school.
Gotcha.
And this was a research project that was funded by Robert Wood Johnson Foundation at the time, where we were trying to address the needs of youth who were at risk for obesity and depression, to try and figure out, what was their awareness of their daily activities, how did that affect their ability to manage their risk, and help them to collaborate with the school nurse and a community health worker that was trained as a health coach. So it was a research project where we developed this app with a private company, and we implemented it at the San Francisco General and at this high school wellness center. So that was our research study that I had started just before coming into the PhD program, and I wanted to study the outcomes and implementation aspects of that program as part of my PhD.
Right. Um, in a general sense, too, let's talk about the Betty Irene Moore School of Nursing in that, right, it was we started with the PhD and master's in nursing science and healthcare leadership. And I remember being on the team and being the one who had to talk to the general public about why we were not starting with an RN degree. And so just, I mean, we're not going to spend too much time on this because there's so many other great things to explore, especially with Health Tequity. But I just wanted to make sure that that was discussed in this podcast because I thought that that was my introduction into how innovative healthcare education could be as well. And the fact of the matter is, you can't expand nursing education and enrollment into nursing schools until you have more faculty. And at that time, that was that was why we were starting with the PhD and master's degrees. So just a little bit about that, and of course, I hope to have Dean Emeritus Heather M. Young on the podcast sometime soon, and really spend some time on that space. But
Yeah, and it was also it was even more innovative in that there are very few schools of nursing who allow non-nurses to enroll in their PhD program,
right,
and I
right,
was
right.
not a nurse. I think that at the time there were only three schools of nursing in the country that allowed that, and I don't know if that's still the same today, but it was an incredible opportunity for me to be able to join the PhD program as a non-nurse. And I really wanted to be there because nursing has the most holistic view of health informatics and the role of technology with both patients and their families. And that was what I was training to do. I really wanted to be a consumer health informaticist. So it was wonderful for me to have that opportunity to be at the Betty Erie Moore School of Nursing as a PhD student when that would not have been available to me at most nursing schools.
This question is just coming into my mind right now, so forgive me for not thinking of it in advance to share with you. But since then, have you been mentoring other students who were non-nurses? Anyway, that's a terrible way to phrase it because it's a very robust and expansive program or school. So I don't want to. Anyway, go ahead.
Yeah, so after I got my PhD, I became faculty at the School of Nursing. So I was on faculty for 8 years, and so I got to mentor lots of students, both nurses and others with other backgrounds. So I was able to, I think, bring my broader background in healthcare to my role as a faculty member. And I think during the time I was there, I mentored 7 or 8 PhD students. A few of them had public health or healthcare backgrounds, and the others had nursing backgrounds. And I continue to teach in the health informatics program, which is actually part of the School of Medicine, but open to nursing students as well. And I continue to mentor students there who come from, actually, a number of them are healthcare professionals who came from other countries, or they're computer science students, or they're from other departments across the campus. So I do get to mentor quite a bit, which I love to do.
Yeah, it's so, I don't get to hear much about sort of technology as part of that innovation space for education. But of course, then the pandemic hit and everybody converted to telehealth. And so that became this big thing. I also think with mental health, there's a lot more in terms of apps so that you can connect more quickly with providers across the country, really. So all sorts of really exciting stuff to continue to explore and research and making sure that whatever is being built is helping individuals and communities with their healthcare needs. So after your PhD, we just talked about you were faculty, but I think you had some other uh, companies that you were working with or creating.
Yeah, so during my time there as a faculty member, just at the end, we had a research grant to assist community health centers. And this is in 2020, so COVID was already kind of raging, and the community health centers did not have a lot of experience in telehealth or any kind of digital health solutions. And at the time, they were not allowed to be reimbursed for telehealth visits. They could be with the patient when they were getting their specialty consult, but the specialist got reimbursed. The clinic did not. So they were not even allowed to do telehealth with their own private primary care patients. And this changed in the pandemic, but at the beginning of it, they had no capabilities really to do telehealth. And so we were trying to find a way to help them maintain connection, particularly with their patients who have diabetes and hypertension, to try and help, patients stay in control while they were not really having access to in-person visits. So we started this research project that we called Activate, along with David Lindemann at UC Berkeley, and I was at UC Davis. We started this research project to develop a system to enable that. And that's what eventually, 4 years later, was launched out of MITRE Corporation and UC Berkeley as a full product to start Health Tequity.
That's so exciting. So, I really want to talk about health equity some more, but just a moment to consider how, and I think about this as myself, right? Like I've wanted to in the past lose 10 pounds or something, but it's really, really hard to, as an individual, take those steps, even though your brain is like, you got to do this. We can make this happen. You can put a plan together, stick with it. But it's still really hard. And when you talk about diabetes and hypertension, some of that stuff, like for me, I was diagnosed with some hypertension in the last 5 years, and I had to like reduce my salt intake, and I had to, exercise more and things like that. And I'm a busy professional, so that's my excuse, right? So how does technology really help the individual make those changes happen?
Yeah, and this all came about because I've had my own experiences with these conditions. When I was pregnant with my son, I was at risk for preeclampsia and had to go on bed rest. And then when I was pregnant with my daughter, I had gestational diabetes and I was on insulin. And so and those things put you at risk after birth, put you at risk for developing those conditions, as chronic conditions long term. So I was monitored, every year, every 6 months, and then every year to make sure that I wasn't developing those conditions. And I think back to those times, and when you're pregnant, you're extremely motivated to manage your health because you care so much about the health of your child. But if you don't have like an urgent reason to pay attention and to change your behavior, many of us don't. When we think about long-term impact, okay, maybe something will happen years from now, but right now I don't feel sick. Right now I'm still functioning. And so there's not maybe a daily motivation to make this the most important change that you're going to make. So recognizing that, I think you have to have some help. And the healthcare system often tells patients, you know, eat right, get enough sleep, get enough physical activity, take
Stop
your
smoking.
medications,
Yeah.
right?
Yeah.
If you're on medication, take your medications. And we all know those things. We know that's the right thing to do. But as you said, it's hard to do on a regular basis when you don't have an immediate urgent situation facing you. And so recognizing that, we knew we had to take a different approach to the use of technology. And so technology in what we developed was a digital care coordination platform that integrated data from remote monitoring devices, and those are your glucometers, your blood pressure cuffs, weight scales, things that people would use at home, and integrated those data into our system to provide real-time access to the clinicians and the staff at the health center. And then through the mobile application, we're also able to show that data to the person themselves. That's only one component of it, though. That is knowing biologically, what your status is. So those numbers are given to you right away. So what is my blood pressure right now? What is my blood glucose level right now? What's my weight right now? And then being able to see those trends will help you to see, okay, what was it yesterday, the day before, last week, 2 weeks ago? Am I getting better? Am I falling backwards? So where do I stand right now in comparison to my trends, my patterns over the last, week, 2 weeks, month, whatever it is? And that gives an awareness to the person of what their status is when you can't necessarily feel what the status is, right? You really don't know if your glucose is high unless it's extremely, like red risk, red flag high. You really
Mm.
don't feel it. Same with blood pressure. You don't feel it, which is why we don't have an immediate reason to pay attention. So those numbers give you an awareness. Do I need to do something right now or in the next, in today or tomorrow? Like in the short term, can I do something to bring that down? Or to put it more in a normal range. And so it gives you that immediate information, immediate feedback. The second thing that it does is it allows you to communicate as the patient with your healthcare provider or your
Yeah.
medical assistant so that you're working on the same numbers at the same time, and you can both say, "Oh, what's going on? How can we, help you to make the change you need each day so that ultimately 3 months or 6 months down the line, when you have your blood drawn or your blood pressure checked at the clinic, it will add up to getting this more in control." But if you don't make the change every day or monitor it every day, those daily changes won't add up to the result that you want. So it helps you to have information that the provider has as well, so you can really collaborate well.
Yeah.
I would say the third thing, though, Kristy, that's really important is that I don't think the technology alone is enough to make behavior change. It gives you awareness,
Right.
it gives you a way to track what's happening, but you still have to have the motivation and the knowledge to make the right changes. And that's why we think it's really important that this is implemented with the healthcare provider in with the clinic so that they can provide that support to the patients. So we even train the medical assistants and community health workers to be health coaches. And these are the staff that are working in the clinic with your provider. And through their training as a health coach, they can actually help you identify your health goals, help you figure out what you're doing right now or in the last few days that is helpful or not helpful, and help you come up with strategies for making those changes that will be effective in the short term that then add up to the long-term outcome.
Right. 100% agree. It's really hard. It takes so much, right, to actually change behavior. I think about my husband, who's been an internal med doc for many years, and talks about how he tells a patient, stop smoking. You're gonna live longer if you can stop smoking, and then they would just walk outside the door and light up a cigarette. So the amount of work, and then I think about on the other side, the team that's there to be those health coaches and staff, and they're actually managing somewhere between 1,500 to 2,000 patients. And then
Yes.
how do they have that ability? So that technology is really the way to connect everybody and help manage their workloads and the individual's behavior in ways that's really exciting. I think there's so much more that we could be doing. And I also think that if you're in a very small practice, that you're not going to have the funding, the resources to build out these systems. So thank you for the work that you do. So let's talk about health tequity and what your vision is. And it's just so exciting. I love talking about it with you previously and happy to record that now.
Well, thank you. So, as I said, Health Tequity was formed by spinning out this technology platform that we built into our company. So we spun it out in April of 24. So we're just about a year and a half old. And we're now providing that to the market. So our first, set of customers are community health centers and public health associations. We'd like to be in, rural hospitals and small community hospitals as well. And that system is really provided as part of a program, as I mentioned. So the technology platform includes the integration of data from the remote monitoring devices and wearables. And it has a mobile app for the patients and then a dashboard for the clinicians and their staff. And the dashboard allows particularly the staff who are monitoring what's happening with the patients, to very quickly see the status of all the patients. Right, where in electronic health records, it's hard to do that. You can see, each patient record at a time, or you could generate a report. But in our dashboard, you're very, very quickly able to see what all the patients are doing. We set thresholds so you can see who is in and out of range, and you can see what their trends are. So you can find very quickly the patients whose trends are worse than you'd hoped, and you can identify them and quickly contact them. And then you can, then have regular contacts with everybody else, so you're helping them to stay on track. But it's more efficient, right, to have a system that allows you to manage a whole cohort of patients rather than just trying to search patient by patient. The other thing that we do is integrate the data with electronic health records. And that way you have permanent record of all the vital signs in the EHR. And that's where the clinicians are going to do all of their work. So they don't want to log into some other dashboard. It needs to be integrated into the EHR. So the clinicians are working in the system they are using every day. So that plus the health coach training program, we provide this entire package to the customers that we serve. So we started in April, we spun out in April of 24. And then we spent some time redeveloping the platform and getting to the next version. And that was launched in December of 24. And now in 25, we have several new customers who we've implemented are actively using the systems in California and in Hawaii. And we are expanding to other conditions as well as incorporating AI into our analytics.
Ooh, let's talk about that.
I thought you might want to talk about that. So, first for the other conditions, other conditions like diabetes and hypertension, where there's a lot of lifestyle and behavior change aspects that people can do to self-manage, and that require really ongoing monitoring and collaboration with the provider and the staff for that patient to be successful in that behavior change. So, one of the areas that we're expanding out to is women's health, and monitoring heavy menstrual bleeding, which is a sign of many, many potential conditions from perimenopause to cancer, right? So lots of different possible causes of that. And we're collaborating with several universities on expanding our platform to support that, as well as to do some early user-centered design research and technology adoption research among women. And so we'd like
Well,
to.
thank you. I'm always out. I feel like I'm always like, we should do more with women's health.
Yeah, it's really an underserved area, and so we're really excited to try and expand out what we can do there. And our mobile application can do things like track symptoms, right? Not just do collection of biometrics like sleep quality or physical activity or nutrition, but also collect symptoms because these are not routinely collected in either private practices, physician offices, or in hospitals. So we don't really know what the full range of symptoms are. We know some of them, but we don't know what the full range of symptoms are, and we don't know which symptoms are associated with, more severe conditions, right? So
Right,
there
like
may just be.
a cyst on the ovary could be we like so getting more data on what that actually is, and then you could really help pinpoint what's going on.
That's right.
Exciting.
So we're expanding that way. And now to our AI work. So we have now been funded by the AI and Aging program from National Institute on Aging and National Institute on Minority Health and Health Disparities. So we received 2 grants in Health Tequity to incorporate AI. So the NIMHD, which is National Institute on Minority Health and Health Disparities, funded us to develop AI agents to support multi-language access in our system. So we will be building in capacity for English, Spanish, and Tagalog, which is a language that people from the Philippines speak, to do 2 different things. One is to allow them to ask the system for things in their own language and to have that translated. So that would be called speech to text, right? So I speak in Tagalog, the system translates my spoken word into text that the computer system will understand. So our computer system runs on English, so it would convert it to English. So the computer or the smartphone knows what this person is saying. But the second thing that it does is it takes that computer command and actually runs it in the system. So now your voice is doing the navigation in the app. It's not just translating the words, it's actually navigating the app for you. So for example,
So cool.
yeah, with the first thing you have to do when you bring up a health app is your username and password, right? If you don't read English or you have some visual issues or your fingers can't really work that small app on your phone,
Yep.
trying to type in a username and password is going to be challenging. So now you could say in English, Spanish, or Tagalog, insert my password. Here's my password.
Yeah.
Insert my username. Here's my username. And the app will actually put it into the right place for you, translated from your voice.
I'm blown away in the moment. I've been trying to help my aging parents with their technology, and oh my gosh, the usage of this would be so amazing for them.
And then the last thing that it would do is, let's say you're logged in and you say, what was my average blood pressure over the last week? In any of those languages, it would go into our database, find your records, calculate the average, and return it back to you. So that would be text to speech, return it back to you and read it in your language.
Oh, brilliant. Yeah.
So it is a set of AI agents that are embedded in our system that allow people to navigate and access information in their preferred language. So we're starting with these three languages. And, on completion of this, we'd of course love to expand that to many other languages.
Yeah.
One of I think the key innovation here is that it's the speech to text and text to speech, but it's also trying to incorporate access for people whose languages are not well represented in AI models. English and Spanish is actually pretty well represented. You could
Yeah.
do a lot with existing AI tools in those languages. But take Tagalog, and the largest database we have found for Tagalog speakers is about 230 recordings. That's not a lot of data.
No, that
So
is
voice
not.
models can't really run for Tagalog. And then many, many other languages like that.
Mhm.
So there's room, and we have a lot of Tagalog speakers.
We
It's
do. Yes.
not that
Yeah.
it's a small population, it's just a small population represented in our AI models,
Yeah.
which is why we selected that one.
Yeah.
So we're trying to expand this accessibility for all languages as well.
Yeah. Um, oh my gosh, brain on fire. I did want to ask about how this will be helpful for rural areas in particular. It's something that you and I were talking about recently, and just to clarify that, I think it helps in that you're talking about the remote access and the ability to have all languages represented in easier way to access the information that they need to improve their health. So anyway, I just wanted to maybe tease out a little bit more about the rural health aspect.
Yeah, I think obviously our populations speak a lot of languages, especially when you're talking about agricultural workers,
Mhm.
right? They're also speaking many languages that are not English. Certainly in California, you know, um, we have in the agricultural workforce many different languages that are spoken,
Yeah.
even though they might be from Central and South America. Spanish is maybe not their first language. There are lots of indigenous languages that are spoken. Mestiza is one, for example, that's pretty well represented in our farm worker population. But Vietnamese, Hmong, Chinese, Korean, Tagalog, definitely, Punjabi or other, Hindu language, Hindi. So this is important because our workforce in rural areas really speaks many different languages. Secondly, they're not always nearby a healthcare provider. Certainly, community health centers are primary providers of care in rural communities, but they're not everywhere. So if you do have a
Or that
condition,
it takes like an hour to drive there and
absolutely, and you
somebody
don't have
might not have a
time.
car.
Yeah, you can, and you can't take a half a day off of work,
Right.
right? Easily. You lose pay, and that's really critical for low income people not to lose, a half a day of pay or a full day of pay. And so, rather than go without medical care, this kind of remote monitoring, remote access to your provider, and providers' remote access to you can really support chronic disease management for rural populations. And it doesn't always need a special a telehealth visit. So it doesn't have to be, log onto an app with enough bandwidth to do a face-to-face,
Right.
video conference. It
Mhm.
can be interacting with the data to know when that's needed, right? It's not always needed. So it helps you to really send your resources to the time and place when it's most important for that provider and patient to interact, and then allow the data and the remote monitoring to provide that information to help you target where the resources are needed. Um,
Okay.
there's one other, and then the language access and that remote access, I think, are the two keys for rural populations. But it also helps the rural providers be more efficient. So, the rural providers, even more than urban providers, have workforce shortages. I know you know this really well.
Yeah. No, I'm thinking of a pediatrician in Willows, which is Glenn County, very rural, and who would see 60 patients a day. 60, like it's a yeah.
And doesn't have a nurse, right?
Right.
It's very hard to recruit nurses in rural areas. There's a shortage of nurses. But even getting a medical assistant, right? Trying to recruit a medical assistant and retaining that medical assistant, that's a huge challenge. There's a great shortage of medical assistants or community health workers, really across the board. And so if you are that provider and you have to do everything yourself, and try to provide access to a large number of patients, it's almost impossible, right? So a tool like this, as I said, will help that provider identify who needs my help the most, who needs it now, or who can wait, till I can talk to them next week or see them in 2 weeks. It really helps to prioritize who needs assistance right away. And for chronic disease management, a lot of times it's not urgent. It's just watching over time, watching those trends and those patterns. And when you notice something going, negative, then having a phone call or having a text message that tries to help that person, sort of maintain their own motivation to get themselves on track. So it enlists the patient as part of the team
Mhm.
to put their
God,
effort
I
in
love
and make
that.
the
I love
most.
that. Yeah, concept of, let's work on this patient, but we're going to do it together with the patient.
Yeah.
You also touched on something that you just reminded me of. So, broadband and internet connections are less available than cell phones, and so having the app and the smartphone is a much better way to ensure that you're reaching more people because there are many places in California that do not have good or even any broadband accessibility.
Yeah, that's a really important point, especially in rural, as you mentioned. So most remote monitoring devices require that you have Wi-Fi in the home, right? With enough broadband or bandwidth to run the app on the phone and do the Bluetooth connection with the device. And you have to have both running. We've actually expanded out our set of devices so the devices can run on cellular only.
Sweet.
It does not require someone to have Wi-Fi in the home.
Mhm.
So it's cellular only, and you don't have to have the app running. That means you don't have to have the app running on your phone. You just take the device out of the box, turn it on. It's pre-configured to connect to activate, and every measure that is taken just is automatically sent to us just over regular, cell phone access. So
Okay.
you don't have to have a cell phone or smartphone. You don't have to have Wi-Fi. It works over cellular towers.
Mm.
And because it's integrated into the device, it's what we would call Internet of Things. that connectivity is integrated into the device. And so the cost of that connectivity is very low. You can do it for $10 or $20 a year.
Mm.
And
Even, yeah, that's another really important point.
it's just integrated as part of the cost of the device. So it
Yeah.
does not cost the participant anymore.
Hmm.
And that's been really important for patient adoption in rural areas. So we're now using that in one of our clients in California and in the Big Island of Hawaii, where their population is quite rural and almost no one has internet access at home. So it's been really
Yeah.
successful.
Yeah, we don't really think about Hawaii's access to care issues, but they are profound and very, very, very challenging.
Yeah.
Yeah.
I do want to go back to our second AI product,
Yes.
which is called a digital twin.
Hmm.
So our grant from National Institute on Aging is for a digital twin of older adults in the community who have diabetes and hypertension. So what a digital twin is, it's a virtual representation of some physical entity. So for example, when medical students or nursing students are trained to do some sort of physical procedure,
Okay.
you
I'm
could
going
have
to ask you to pause right there. I'm so sorry. Just one second.
So a digital twin is a virtual representation of some physical entity, an engine, an organ, a person, or a healthcare setting. So, for example, when nursing or medical students are trained, they're often trained in a simulated environment, right? So we have dummies, right, that we train nurses to do vital signs, to do nursing assessments, to do, procedures to understand what's happening with that patient. So that dummy is actually trained on many real cases, but it is embedded the data and the algorithms to act as if it's a real patient, right? And so when a nursing student does a certain procedure, that is the real world input. The nurses is actually, manipulating the dummy. That real world input is taken into the dummy, and the dummy is reacting to that as if it were a real patient. But the dummy doesn't know in advance what the nurse is going to do, right? So it's not that it has pre-programmed exact pathways. It knows how to react to whatever the input is. Okay, so that's a version of a digital twin. So now let's take that concept to a population. So we have a population from the clients in Activate. We have a population of patients all served in community health centers in primarily rural areas. And the data we have are the remote monitoring data, the clinical data from electronic health records, the payer contract data, what they were contracted for, what they were actually paid, and then things like administrative data like demographics and things like that. So we basically have all the data from a community health center. What we'd like to do is to say, now let's take the patients with diabetes. What's their likely trajectory of their illness? If they have a certain condition today, what might they look like in a year from now, or 2 years from now, or 5 years from now, if we just do the same thing we're doing right now? Now, let's say we start them on remote monitoring, so we give them a glucometer. We have data from our actual implementation of the patients who got glucometers and what happened to them. We also have data on the patients in our previous study who did not get the glucometer and what happened to them. So now you can use that big sample of data to predict what might happen to a new patient if you did or did not start a glucometer, or if you did or did not start health coaching, or if you change their medication, or if they lose their insurance and now start to self-pay. We can actually predict all of those changes over time. So that's what the trajectory, what change over time. So now think about that on a very large population basis. Now let's look at all of rural California with patients with diabetes, hypertension, or both, who are older adults. And we can pick our population, 50 and older, 55 and older, 60, 65, you can pick the age range that you want to simulate. If I have somebody who is 65, has both diabetes and hypertension, They're, over stage 2 hypertension. They're, 11 points hemoglobin A1C. They're not doing well. What if I now enroll them in health coaching? Could I expect them to get better, and how quickly? If I add health coaching plus remote monitoring, what might happen? If I just do medication change, what might happen? So now I have a way to simulate what could happen to this new individual who's not in the program based on all the data we've collected from people who were or were not in the program in the past. So we can now predict it. The change here, so that's what a digital twin is. We're simulating the population of patients in community health centers with diabetes and hypertension so that we can predict what might happen to them if we try different intervention programs.
Um, I'm so blown away with this because I feel as if, I think we talked about this previously, that like there's all this data and it's out there everywhere. How can we use it to improve people's health? And this is just such a beautiful way to do that. And it's exciting. Is Health Tequity the only organization that's using digital twins, or is this, I want to talk about Health Tequity, but I'm curious
Yes.
if it's like if you're leading the field or what's happening out
Yeah.
there.
It's interesting because we applied for this grant, um, you know, uh, probably late 24,
Hmm.
2024. And then we were awarded it in January. So at the time that we submitted it, we've been watching the literature very closely, and almost nobody was doing digital twins in healthcare. And the Gartner hype reports, hype cycle. So Gartner published these hype cycles, and they did an AI hype cycle. And in 2023, they did a hype cycle, and they had digital twins on there. And they said it's probably 10 years out. Okay. So
You
then
you
we get
raised
our
your hand and you're like, hello, we're here
Yeah.
right now.
No, but then we get our grant, we start working on it, and just this year, you're starting to see lots of people saying they are going to work on digital twins. Gartner's hype cycle for 2024 said digital twins are now 2 to 5 years away. So in the space of 1 year, it went from 10 years to 5 years or less. So this field is moving very quickly. So I don't want to say we're the only ones because we don't know everything that's going on. There are a lot of people saying that they are working on digital twins. I think there's a couple of key things that we need to know about digital twins. One is, so I've explained basically what the digital twin is, but the second is because it's a virtual representation of a physical entity or a physical machine, you have to keep getting real world data to test that your machine is still working. So in our case, you need the EHR data to continue feeding in to say, okay, we started on this medication 2 weeks ago. How is it going now? Because the machine needs to keep simulating whether your
Right.
outcomes are what it was predicted. Otherwise, it's just a prediction that has you can't improve on it, right? So you need the real world input to continue improving. So it's a dynamic engine,
Yeah.
reacts to what's actually happening to you. So it needs to be implemented in a healthcare setting where the data continues to feed it so you can keep updating it. That's really critical. So it has to be part of the operations of a healthcare setting.
Hmm.
And most of these, organizations aren't there yet. Most of the digital twin companies are not there yet. The second thing that we think is really important, and this was validated by the National Academy of Medicine that wrote a report on digital twins a couple years ago, and they said if you cannot assess how trustworthy your predictions are or validate the accuracy of your predictions, the digital twin can't work in healthcare. So you have to have some way of knowing if my predictions are trustworthy. And as you know, AI is a black box. A lot of times we don't know what the algorithm is. We don't know how accurate or how sensitive it is. So that's why a lot of AI doesn't work for us in healthcare. So part of our grant is actually to develop trustworthiness metrics. So we're
Hmm.
developing uncertain calculation of uncertainty. How certain is our prediction? So that you, as the provider of the health system, can actually compare those and make judgments about what you'll do. So that's the other key difference in what we're doing versus a lot of other digital twins.
So, and I'm not so much in the research world at all, but it sounds as if the AI, the digital twin, is um, an, a more comprehensive way of proving a research predict, right? So we know that if a patient uses the glucometer, that they are going to improve their health outcomes. Um, and then the digital twin can be used to support that premise, right? I mean, I know I'm breaking this down way too simply, but
No, that's exactly right. That's
it's
exactly right. To support that
interesting
premise.
way to like inject some steroids into the research process.
Yeah, that's a good way to think about it.
And also speed it up a little bit. I did work a little bit on mental health and how it's bench to bedside is like 18 years. And in a
Yeah.
lot of cases, there's people who are dying in the middle of those 18 years. And so this could be a fantastic way, if used correctly, to really get some new methodologies into people's hands. But also, what an amazing way to yeah, be innovative in medicine, nursing, all of these education spaces. And I hope that the future will be that this is part of those education pathways because, you know, the more people who understand how to manage these digital twins and get to better health outcomes more quickly, you know, the better we will all be.
Yeah, I absolutely agree. And bringing it back to, because your previous question was, what about rural?
Yeah,
I think this is really critical for rural communities because right now, we already talked about how AI models don't have other languages. AI models also don't have data from rural communities or from under-resourced communities. Most of the
right.
data comes from large
Who
hospital
has
systems,
time? Who has time to collect and report and share? And you know,
right?
they're just busy trying to make sure that all of their patients get the care that they need right there. A very responsive world that rural healthcare is in.
That's right. So the data is coming from, or the data are coming from large academic medical centers, which are primarily urban, because that's who has time to collect all these data, integrate data into these big national databases, and make them available for research or AI companies. So rural is not represented. That's the other reason we wanted to do this. As we expand out to community health centers, rural hospitals, small community hospitals, we want their data to be represented so the models can be built that represent their patient population so they can be used for accurate simulations and predictions. If their data is not in there, they'll have the same problem translating what happens in clinical trials to their real populations, right?
Yeah.
Because it will be based on their data, not on a whole different set of patients that they never see.
Right. And and if people say, well, humans are humans, you know, you just have to remind folks that where your zip code, where you live, what your zip code is, actually is a stronger prediction of your own individual health outcomes than most other things. I might not be saying that correctly, but
Right.
your zip code actually really matters to your health.
Absolutely, because that represents everything going on around you, right? It represents your not just your individual status, but the economic status of your whole zip code, what access to healthcare you have, what kind of food is available there, the transportation options, the environmental conditions, right? Your zip code represents a lot of these things that we don't necessarily know at an individual level in the hospital records.
Yeah.
So, knowing as much about the group of people in a rural area can really help you identify what risk and what interventions might be helpful to any individual person in that area.
Yeah, just a simple data points that like in north of Sacramento, there's higher rates of pancreatic cancer. In zip codes where there isn't insurance coverage or people aren't taking advantage of insurance, they're more likely to die of prostate cancer because they're not getting the preventive support that insurance can help provide folks. So yeah, it's really helpful for rural communities to have a better understanding of where they are in terms of data right now, but also how to get to a better, healthier future. And it's not to say that rural is unhealthier. There's not as healthy as urban or any of that. It's all very intertwined. But yeah, the digital twin can really be helpful. But also for that simulation learning, I think, just to embed that into nursing education, medical education, all of that. So if you were building a new medical school, let's just say, or a school of nursing, or what would you wish to see in that curriculum so that all of us are going to be able to be leaders in this space or utilize the space or manage it or whatever is going to be prevalent in 10 years time?
Well, I think, the Betty Arion Moore School of Nursing did one thing that was great. I mean, they did many things that were great, but one thing that comes to mind is that they made health informatics, the introductory class, a requirement for all the nursing students. That's really phenomenal. So that there's a basic understanding of technology, of data, of methods to analyze those data for all nursing students because they will all every day have to understand these things, whether it's just using the electronic health record or whether they go into quality or management, executive roles, or they go into nursing informatics. They all need to have that basic understanding. And I think med students need that as well. So one is to make sure there's some introductory health informatics training in the curriculum. The second is to expand out on the types of technologies that we teach about. Go beyond the EHR and look at things that patients are using in their daily lives. They're using fitness watches and they're using mobile apps, and they're using self-tracking types of technologies. We need to know about those in healthcare, and health professionals specifically need to know them because their patients are using them, and they have to know what to do with those data, what to use and what to ignore, right? Because
Hmm.
we don't want every single thing that a patient tracks for their own purposes. It may not be clinically relevant. So what do we use and what do we ignore? And they can then contribute to systems that will be relevant to the clinician's practice. So I would say that there needs to be an expanded introduction or training on consumer use technologies and the data that comes from them so they can be incorporated into decision support, into predictive analytics and other systems that the clinicians will use in their practice.
Yeah, it's just occurring to me. So I got an Apple Watch and really started tracking my sleep patterns every night because I wasn't getting enough sleep and it was tied into a whole bunch of other things. And I've now gotten up to 7, sometimes 8 hours a night. So I'm very excited about that. And it really does
Nice.
help me. I'm a better person. I'm a healthier person when I sleep more, right? So but if I have too much sodium, so I was able to look at that pattern, my sleep pattern, and how if I felt like my sodium was just too high, I was going to have a disruptive sleep. But anyway, like, how do I bring that to my doctor? And I'm like, look at my sleep data for the past year. And, like, he'd probably be like, oh, okay, well, great. Your hypertension's down. Fantastic. But like, yeah, I'm doing all this stuff at home. And how do I help my doctor see that too? But then how does that all go into the digital twin too? Like, who knew that sleep would actually help with hypertension or,
Right, right.
it's all connected.
Yeah, it's all connected. And you are the perfect example of that empowered patient who becomes a partner with the doctor in that healthcare team. That's exactly what we want, right?
Right. But then how do I communicate that to him?
Yeah.
I,
So that's a good example of where your individual provider maybe doesn't want all that data from you, like every,
right.
if
Shut
you
up,
were in
Kristy.
order, right? Yeah, they don't need all that. But to know that you are using an Apple Watch or an Oura Ring or, whatever it is, and that you've identified this pattern that sodium has an impact on your sleep, and now you've reduced your sodium and you're getting 7, 8 hours of sleep a night, that might be enough information for the doctor,
That's
right?
interesting.
Just to know that without having individual data. But if you were to be in a research project and they asked you to contribute your
Right.
wearable device data, and your symptom data and all of that, then they might be able to look at a whole group of patients who are using those devices and say, we see this trend. And then we can publish those findings that then contribute to what clinicians will use in their practical applications.
Really, so it's taking those clinical, trials, if you will, and turning it inside out, right? So like making it available for all of us to be able to participate in these things, and it's not causing harm. It's actually, helping
Yeah,
people improve. So,
absolutely.
IRB. So I think our time is quickly coming to an end. Is there anything that you would want to say to a student who's going into healthcare, what nursing, medicine, physical therapy, all of these things? What would you want them to know now for the future?
I think one thing that I've kind of always hoped for is that healthcare professionals would not be intimidated by technology, because I think sometimes those who are not in the technology world hear these things and they think, oh, that's just too hard for me to understand.
Or one more thing to add to my
One
plate.
more thing to add to my curriculum. And, I just don't have time for that. I hope that they will get excited about the opportunities in technology, be interested in learning a little bit more about them, not how to be a programmer or not how to, be an analyst, a data scientist, but just to understand the practical applications and why they're important for health and why patients are using these things, whether they've been prescribed or not, um, and be willing to, understand how this can help them be a better clinician. And I think by including some of this training in the curriculum, also by just sharing these kinds of, program outcomes that are really beneficial, can help, students to see that connection.
Okay, and then what is your website, just in case anybody hears this podcast and wants to reach out to you?
Yes, our website is healthtequity.net. So it's HEALTHTEQUITY.net. So healthtequity.net. And we have videos on there. We have about the AI work that we're doing, as well as the remote monitoring and care coordination work. We have papers that we've written about it, and we have some news coverage that we've received about these projects. So hope you will go there and learn more about us.
And I'll definitely put that in the description of this podcast. So it's a link that people can go to. Thank you so much for sharing your thoughts today, and so exciting. I think my brain is on fire right now with in terms of mental health, because there's just I think that's just that a field that we could really benefit from all of these things, down the line sooner rather than later, but
Yeah.
that would be my hope.
Yeah, absolutely. Agree
All
with
right.
you.
Well, thank you so much, and we'll talk soon.
Thank you, Kristy. Bye.
Lost my sense of humor, I've them to Fontenelle. Hovercrafts, blow up kayaks, would have helped with angry toes, but it gave mashed potatoes. Take that meatloaf back, hi! Birthday dehydrated cake and lots of wine, so nice with clean dark hair. I think it's a waltz, I think it's a waltz, but I know it's the longest 2 miles of her. I think it's a waltz, I think it's a waltz, but I know it's the longest 2 miles of her.